Hi, welcome to our session on case-based learning. Today I have a 9-year-old boy with cervical adenopathy and what are all the investigations that will be helpful to find out the cause behind this cervical adenopathy. First of all, you all know that majority of a pediatrician's clinic will be started with cervical adenopathies and whether to investigate or not. That is the million-dollar question. When we need to investigate, the answer is very simple. We need to investigate only significant cervical adenopathy. What do you mean by a significant cervical adenopathy? A cervical adenopathy of size more than 2 centimeter, and if it lasts for more than 2 weeks, it is a significant cervical adenopathy. Then you need to investigate that case, right? Apart from that, what is the rule of 2? The rule of 2 is simple. As we mentioned already, if the node is more than 2 centimeter and if it lasts for more than 2 weeks and if it doesn't respond to 2 weeks of antibiotic, can we try antibiotic without any signs of underlying inflammation? The answer is yes. You can try narrow spectrum cephalexin or cefadroxil or a broad spectrum clindamycin if your area is studded with MRSA bugs. If there is a history of cat bite, instead of cephalexin, cefadroxil or clindamycin, you can try macrolide because it can be due to a cat scratch disease, for which you need to try macrolide instead of beta lactams, right? So you need to investigate a significant cervical adenopathy only. Right now, I have a 9-year-old child. Look at this. This is definitely a significant cervical adenopathy involving the posterior triangle of the neck. Definitely, it is more than 5 into 7 centimeter, but there is absolutely no tenderness, no lymphadenopathy elsewhere. There is no organomegaly. Manto done outside turned out to be 20 and it is done with 2 TU units. And FNA done outside revealed an ill-defined granuloma. There is no mention on caseation and CB nut was not done. And the child was started on ATT elsewhere. Even after 4 weeks of ATT, the node doesn't regress in its size. So the child was referred to ICH. Right now, what you are going to do? Is it TB? First of all, in a country like India, look at the node. Probably it is a mated node. It is a huge node. Is it TB? With an ill-defined granuloma, manto positive, it could be TB. It could be TB. And you all know that it can take almost even 3 to 4 months for the cervical adenopathy to resolve. Some cervical adenopathy, even after ATT, do not resolve at all. Choice number 2. Is it due to drug resistant TB, particularly if it is due to H resistant, then adding levofloxacin could be of any use in this case? I really don't know. Third, can it be an Hodgkin's lymphoma? Can it be due to a mixed cellular variety? Should I go for an excisional biopsy in this case? Ideally speaking, you need to go for an excisional biopsy in this case. So whenever you plan for excisional biopsy, invariably you need to take a urea, creatinine, simple blood investigations to get an anesthetic fitness. It is mandatory. Shall we do CBC in this case? Do you think that CBC is going to be of any help in any case of cervical adenopathy in a 9-year-old child? Absolutely, I don't think so. Next, serum LDH and uric acid. What for the serum LDH and uric acid? Could it be due to a manifestation of T cell leukemia or lymphoma in which uric acid and LDH usually rises and give us a clue towards proliferative lymphoproliferative disorders? Or shall I try one more? Aspirate and do a culture. It can be a bacterial culture, fungal culture, or it could be due to, we can also do TB culture, MGIT. So what we are going to do? Even though there is a mention on manto, with respect to 2 TU and it is positive 20 mm. With an ill-defined granuloma, I don't have a contact and I don't have a caseation. And the child is not responding as such. So instead of directly waiting for the observation or adding a levofloxacin, let me try to do an excisional biopsy. We also plan for excisional biopsy. Before excisional biopsy, we used to take urea, creatinine, PT, APTT for surgical purposes. Along with that, we took CBC also. And by surprise, the CBC itself had given us a clue. What is that clue? Let us see. Total count 3000, ANC 1500, ALC 1500, platelet 1 lakh, CRP 4 milligram per deciliter, and ESR 80 millimeter of mercury in the first star. Can you tell me the answer? Yes, when you have a significant cervical adenopathy with leukopenia, lymphopenia, thrombocytopenia, normal CRP and an elevated ESR is nothing but, you are correct, it is Kikuchi-Fujimoto disease. It's very easy to identify a Kikuchi-Fujimoto disease by CBC alone without doing an excisional biopsy. In fact, excisional biopsy should be done, but the purpose of this discussion is how CBC is going to help in many cases of cervical adenopathy. And you all know that Kikuchi is a forerunner of systemic lupus erythematosus, right? So what is the lesson learned in this case? What is the role of CBC in cervical adenopathy? Case 1. When you have a total count of 3000, a platelet of 1 lakh, ESR of 50, CRP of 1, must be Kikuchi-Fujimoto disease unless otherwise proved. 2. Right now I have a case in which the total count is 30,000, ALC is 20,000, I have anemia, I have thrombocytopenia, and my MCHC is 38. That means spirocytes are present. Cervical adenopathy with absolute lymphocytosis along with bicytopenia, otherwise the child is healthy. You need to think in terms of an Epstein-Barr virus. Okay? Not that much sick to the extent of an acute lymphatic leukemia. Second is EBV. Third, right now I have a total count of 30,000, ANC of 20,000, CRP 40, ESR 60, platelet 5 lakh. So what is this? I have neutrophilia, inflammatory markers such as ESR and CRP, and with thrombocytosis. What is the diagnosis? If it is an infant, you are all correct. It could be a Kawasaki disease. But if it is a older children, think in terms of SOJIA. What is that? Systemic onset juvenile idiopathic arthritis. And don't forget, a simple bacterial adenitis can have this kind of inflammatory markers. So it could be due to acute bacterial adenitis, Kawasaki disease, or SOJIA. Next. Look at this case. The total count is just 4,500, but predominantly absolute lymphocyte count is high. ANC is just 500, hemoglobin is just 5 grams per deciliter, platelet is 30,000. Here also I have an absolute lymphocytosis with anemia and thrombocytopenia, but in this case the child is sick. In pediatric age group, whenever you have anemia and thrombocytopenia in the presence of lymphocytic pleocytosis, whatever the complaint is, you need to think in terms of an acute lymphatic leukemia. Next, total count 6,000, ANC 4,000, ALC 4,000, ANC 4,000, ALC must be 2,000. Hemoglobin 10 grams, platelet 4 lakh, ESR 50. So that ALC must be around 2000. Okay. So what is this actually? A normal total count, a normal lymphocyte count, a normal platelet, but ESR is little bit elevated. This could be TB. I am not going to say this is TB. This could be TB. And remember, in peripheral smear, lymphocytosis doesn't mean that you are dealing with a case of TB. Whereas in tissue fluids like CSF, your pleural fluid, pericardial fluid, ascites, if you have a relative lymphocytosis, then you can think in terms of TB. But in smear, presence of lymphocyte doesn't indicate TB, right? Next, total count 4000, ANC 2000, ALC 2000, platelet 1.1 lakh, ESR normal, CRP normal. What is this? A borderline lymphopenia, a borderline leukopenia, a borderline thrombocytopenia with a normal ESR and CRP. Yes, you are absolutely correct. This is post-viral adenopathy. Majority of the cases that we are dealing in our outpatient is post-viral adenopathy. So this is all from my side. Thank you.